Good evening, everyone, or good morning, or good afternoon, depending on where you are and where you're listening to this talk. Thank you for attending this lecture. Thank you for spending the next hour or so with me. My name is David Eisen. I'm a dentist from Toronto. I have a sedation-based dental practice where I treat people who have special needs for their dental care. And as well, I do a little bit of lecturing here and there on topics related to local anesthetics and medical emergencies in the dental office. I'd like to thank Purell Pharma for sponsoring this talk today. Purell Pharma is an international manufacturer of dental local anesthetics. I'll be talking about one of their products later on, and they've kindly sponsored this talk, and once again I thank them for the sponsorship. So without any ado, let's begin the talk. The talk is titled What's New in Local Anesthesia? And we're going to go through this, and again, it'll take about an hour. Then there'll be a chance for some questions and answers as well. So I have this talk divided up into three categories. The first will be newer research that's appeared in the literature over the past few years. Now, not all of it is brand new within the last 5 or 6 months, but it's within the last few years. And the papers that I've chosen to talk about are ones that I think really can change the scope of how we administer local anesthetics. So they're, again, not all brand new, but important over the last few years. Secondly, we'll talk about new drugs that are available for dentists to use that have to do with local anesthesia. And finally, we'll take a look at new devices that have become available. And these devices are things that not only help us administer local anesthetic, but maybe make our patients more comfortable and achieve more profound anesthesia as well. So first, to begin, let's talk about some of the newer research that's come available over the past little while. And I've got 5 different categories of this new research. We'll look at the enhancing local anesthetic efficacy. We'll look at some articaine research. We'll take a look at inferior alveolar nerve blocks and third molar development, pregnancy, and finally injection speed. So, what about local anesthetics and inflammation? Inflammation, many of us know, really can wreak havoc on our ability to get good anesthesia. Infected and inflamed tissue is acidic, and the acidity of the tissue actually stops the local anesthetic from doing what it needs to do. It stops the local anesthetic from working properly. Teeth that have pulpitis, we know they're harder to get numb, and part of the reason for that is the acidic nature of the infection and inflammation that surrounds these inflamed and infected teeth. Even with inferior alveolar nerve blocks, where the area of infection is a good distance away from where we are operating, we're delivering our anesthesia far away from where the area of infection is. Still, in these cases, sometimes local anesthetics can't work as effectively as we wish they would. And this is something that we have to deal with, and there are ways that we can solve this problem. One clue, if you're doing restorative dentistry, for example, you're not doing a root canal or you're not doing an extraction, you're trying to just restore a vital tooth, and you don't have good local anesthesia after administering local anesthetics, you might take a periapical radiograph and see whether or not the reason for the failed local anesthesia is the fact that the tooth actually needs a root canal and not a restorative treatment. And it's that infection and inflammation associated with the need for endodontic care that's actually stopping the local anesthetic from working. So this study was done to look at the possibility of non-steroidal anti-inflammatory drugs enhancing the efficacy of local anesthetics in areas of infection and inflammation. The researchers divided their cohorts into 3 groups of 50 people, and each person received a drug 1 hour before the administration of local anesthetic. So the cohort patients in group 1 received 75 milligrams of indomethacin, which is an anti-inflammatory drug. Group 2 received 600 milligrams of ibuprofen, of course, another anti-inflammatory drug. And group 3 received a placebo. Then, 1 hour after the administration of one of these 3 drugs, everybody received an inferior alveolar nerve block with lidocaine, 1 in 100,000. And then the teeth were tested with a pulp tester to see how well anesthesia was achieved in these teeth. The 2 groups that had the anti-inflammatory drugs, the ibuprofen and the indomethacin group, had a higher success rate of anesthesia compared to the placebo group. So you can see the placebo group only had 32% success of anesthesia. The ibuprofen group had 78% success of anesthesia, and the indomethacin group had 62% success of anesthesia. And that's significant, that difference. So this shows us that anti-inflammatories in areas of infection and inflammation can help local anesthetics work more effectively. For your patients in your practice, this might be something you employ before treating patients with infection and inflammation. For example, if you're extracting a tooth that has severe periodontal disease, or you're doing endodontic procedure on a tooth that has a recognizable periapical radiolucency or swelling, the treatment of an anti-inflammatory, if the patient is medically able to take such a drug, can increase the effect of the anesthesia if we give this drug an hour before, or maybe 12 hours before, or maybe even putting our patients on a regimen 24 hours before they come into our office to have these difficult areas treated, which sometimes can be quite painful. The second study that I'll show you had to do with the use of nitrous oxide and its ability to enhance local anesthesia. So here again, the study group are people with pulpitis, so they have inflamed teeth, and they were all mandibular molars. And the researchers wanted to know if using nitrous oxide would help the efficacy of the local anesthetic. So 2 groups were studied. Group 1 received oxygen only and local anesthetic, and Group 2 received nitrous oxide with a mean concentration of 43% and local anesthesia as well. The differences were such that the group that had nitrous oxide had a 50% success rate of anesthesia for these hot mandibular molar teeth, and the group that had only oxygen and local anesthetic only had a 28% success of anesthesia. Now, why did the nitrous oxide work? What is it about nitrous oxide that enhances the efficacy of local anesthetics? I mean, it could have been that the patient was more dissociated and didn't recognize the pain anymore. It could be that nitrous oxide is a vasodilator, and maybe vasodilation in the area of injection enhanced the efficacy of the local anesthetic. Who knows? Either way, this is something that helped in this study and something that we might want to employ in our practices when we're working on these teeth that are very difficult to get numb. The third study, and this is quite an interesting one, I think, is the addition of something called mannitol to local anesthetic. Now, mannitol is an alcohol sugar. It's classified as an alcohol sugar compound. Of course, it's found naturally in the plant world. But in medicine, mannitol is used, it's an additive to drugs because it helps drugs cross the blood-brain barrier. Mannitol on its own crosses the blood-brain barrier very effectively. So the question was posed, if we add mannitol to local anesthetic, will a local anesthetic be able to cross the nerve barrier, which may be similar to the blood-brain barrier, and would mannitol enhance the efficacy of lidocaine penetrating the nerves, thereby increasing its efficacy for anesthesia? So again, the percentage of teeth that were numb with a pulp tester is what this study looked at. So you can see on the left side of the screen, the lidocaine-only group had, for second molars, 68% success of anesthesia. First molars, 58%. Second premolars, 58%. First premolar 64%, lateral incisors 31%, central incisors 16%. Adding mannitol to the local anesthetic, to lidocaine, statistically significantly increased the efficacy of the local anesthetic. So this is interesting, and maybe something we'll see somewhere down the road where mannitol or other additives similar to it are added to our local anesthetic cartridge or vial, whichever form we're using, and maybe increasing the efficacy of the local anesthetic. So next, let's take a look at articaine and look at some recent studies that have been done using this local anesthetic. These are very interesting because, at least in North America, the results of the study actually allow us to use articaine differently than the standard ways we are taught in dental school to achieve local anesthesia. And specifically, I'm thinking about the mandible. So articaine is an amide local anesthetic. But it's different than our other amide injectable local anesthetics like lidocaine, prilocaine, bupivacaine. Articaine is metabolized in the blood by an enzyme called pseudocholinesterase. 90% of articaine is metabolized in the blood. The rest is metabolized in the liver. Unlike our other local anesthetics, our amide injectable local anesthetics are metabolized in the liver. And therefore, if somebody has liver disease, we have to be careful, minimize the dosages of anesthetic that we're giving them. Whereas with articaine and liver disease, we can safely use the normal dose range for that patient, regardless of how well their liver is functioning or not. Articaine is also different because it's metabolized more quickly than our other injectable local anesthetics. It has a half-life of about half an hour. Now, what does that mean? Well, that means theoretically we can actually inject more of it safely sooner because it's broken down more quickly in the body. So later on in a procedure, if we require more local anesthesia or if we have other procedures to do, after half an hour, 40 minutes, we can be sure that half of the drug has been broken down in the body and we can safely administer another dose. Now, that being said, even though this is the case, we have to be very careful if we employ this method because articaine is a 4% solution. And as a 4% solution, it is twice as toxic as a 2% solution like lidocaine. So articaine and lidocaine both have the same maximum recommended dose. They both have a 7 milligram per kilogram dose range or a maximum recommended dose of 500 milligrams for an adult, but articaine is 4% and lidocaine is 2%. Well, that means you can only give half as much articaine compared to lidocaine because there's twice as many molecules in the cartridge and it has the same maximum dose recommendation. So we can inject it sooner, true, but we have to be very careful doing so because we can only give half as much as compared to lidocaine at a time, per sitting, per appointment. And again, even though half-lives might have occurred, we still can't surpass the maximum recommended dose. So 500 milligrams is all we could give to an adult in one appointment, regardless of how much time has gone by. The other difference with articaine is that molecularly it has a different shape. So instead of a benzene ring, it has something called a toluene ring, which has 5 sides instead of 6. And also it has an extra ester link. And theoretically, the thought is this ester link might make articaine more lipid soluble. And that's an important property for a local anesthetic because lipid solubility is what allows the local anesthetic to penetrate the nerve membrane. Without lipid solubility, an anesthetic won't work. So maybe with this extra ester link, articaine is a little bit more lipid soluble and might give us a little bit better anesthesia in certain situations, which I'll talk about in a few minutes, because of this molecule and the differences with the other amide local anesthetics. From an efficacy perspective, when we talk about blocks and infiltration, I'll show you some meta-analysis studies that show as a blocking agent, articaine is no better than any other local anesthetic available. So if you compare articaine to lidocaine, bupivacaine, prilocaine, it has the same efficacy as a blocking agent. However, as an infiltration agent, again, I'll show you the research in a minute, articaine is more effective for infiltration anesthesia. And finally, there is a concern, albeit an anecdotal concern, that 4% solutions, not just articaine, but prilocaine as well, when used as a blocking agent, may have a higher risk of paresthesia after it's used. Now, again, these are anecdotal reports, and they are not scientific, multi-dose centered, randomly controlled trials. They're anecdotal based on past complaints that can be found in different places. So articaine can be found, a number of different companies sell it. In North America, this slide shows you the companies that sell articaine, and you can see the percent of this drug in North America is always 4%. I believe there are places in Europe where you can get it as a 3% solution. And in North America, the concentration with a vasoconstrictor is always either 1 in 100,000 epinephrine or 1 in 200,000 epinephrine. So we have a choice of one or the other. From the perspective of efficacy, again, more vasoconstrictor will not give you any better efficacy of anesthesia. The only advantage of more vasoconstrictor is more hemostasis. So that's a consideration. I think 1 in 200,000 epinephrine is a very nice concentration of vasoconstrictor because it limits the amount of vasoconstrictor we're giving to our patient, yet at the same time it gives us the maximum amount of duration and efficacy as we would expect from the addition of a vasoconstrictor to the local anesthetic cartridge. So this is one of the newer articaines that's become available in the marketplace, and I show you this one again because it is one of the newer products, and this happens to be the articaine that is supplied by Purell, the company that's sponsoring this talk. Now the reason I'm highlighting this specific articaine is because it is a little bit different than the other articaines that I showed you in the previous slide. And the main difference with this solution is the way it's manufactured. The OraBlock articaine is manufactured under an ongoing aseptic process. That means each step along the way of the manufacturing process is aseptic. And because of that, something called terminal sterilization is not required. Every other local anesthetic manufacturer that doesn't manufacture their product under aseptic process must terminally sterilize their product so that the end result to the dental office is a completely sterilized solution, cartridge, package, and so on. So there's two different processes. One doesn't give us a more sterile product than the other. They both result in the same sterility in the end. But with the ongoing aseptic process compared to the heat terminal sterilization, this product is allowed a longer shelf life because there's less breakdown of the preservatives in the cartridge when the aseptic process is used as opposed to heat terminal sterilization. So you get a 24-month shelf life for OraBlock compared to an 18-month shelf life of the other local anesthetics. The other thing that may be not a concern or a factor, I think, but just a fact, is that with terminal sterilization, there may be some amount of impurity in the local anesthetic cartridge. Now, I have no idea how that measures out or what that means, if anything. Now, I don't think it does. I don't think it means anything to the patient, nor do I think it means anything with respect to the efficacy of the local anesthetic. Now, this study is the one that I really want to highlight when we think about using local anesthetics in the mandible and how articaine really can change the face of what we do to our patients. So really, in dental school, we're all taught to anesthetize the lower teeth, the mandibular teeth. We really have to do an inferior alveolar nerve block because the buccal bone is too thick to allow an infiltration in most cases. Articaine is different. In fact, there are plenty of studies to show that articaine is pretty successful if you use it as an infiltration drug in the mandible. So here's one such study. This study compared articaine and lidocaine, both 1 in 100,000 epinephrine, and infiltrations were done in the mandible besides second molars, first molars, second premolars, and first premolars, and then pulpal anesthesia was measured with a pulp tester. And you can see the success rate of articaine is significantly higher than it is for lidocaine. So 75% for second molars, 87% for first molars, 92% for second premolars, 86% for first premolars. That's pretty good. I mean, if you take a look at these numbers and think about what our percent success of anesthesia is for these teeth after inferior alveolar nerve block, these numbers compare quite well. In fact, the literature tells us that the success for anesthesia of mandibular teeth after an inferior alveolar nerve block is around 80%. So you can see that for first molars, second pre and first premolars, articaine is surpassing the average success rate of an inferior alveolar nerve block injection. So this is something that we might consider in our practices when we think about how to use articaine a little bit differently. Some tricks to enhance the success of articaine as an infiltration drug. Maybe consider using the 1 in 100,000 instead of the 1 in 200,000. Maybe the 1 in 100,000 will vasoconstrict the vessels in the area, thereby keeping the local anesthetic locally for a longer period of time, giving it more time to diffuse through the thick buccal cortex. Choose smaller patients, females especially, people with thin bone, thin buccal cortex. This is going to be more successful. Studies show that if you supplement both an inferior alveolar nerve block with an infiltration or an infiltration with an inferior alveolar nerve block, the success of the two is better than the success of each alone. So they complement each other and give you a higher success rate if you were compared to if you were doing either of these techniques by themselves. The other way to enhance the efficacy of a buccal infiltration in the mandible is to supplement it with a lingual infiltration. And this is a nice trick to use, especially if you suspect accessory nerve innervation to the mandibular posterior teeth, where the mylohyoid nerve might send an accessory innervation to the mandibular tooth, and usually that accessory nerve enters from the lingual side, even through foramen that exist on the alveolar ridge. So doing a little lingual infiltration, now this should not be done in the floor of the mouth. Of course, this is where the submandibular salivary gland would lie. You'd want to do this right on the alveolar ridge. Try and get that foramen or that accessory nerve on the lingual side of the tooth that you're working on in the mandible. And again, not in the floor of the mouth. So the question that I'll pose to the audience is a successful buccal infiltration with articaine equal to or better in some cases than the success for an inferior alveolar nerve block with any local anesthetic? Now this was an interesting study, sort of to highlight what I'm saying here. This study looked at a secondary technique after a failed inferior alveolar nerve block. So this was done again in the mandible, once again done on teeth that have pulpitis, so teeth that need endodontic treatment. And they chose teeth that were being operated on where the person doing the study did an inferior alveolar nerve block with lidocaine, and it failed. After the failed inferior alveolar nerve block, the researchers did one of 4 injections. They did either a second inferior alveolar nerve block, or a buccal infiltration with articaine, or a PDL injection, periodontal ligament injection, or an intraosseous injection. They studied which of these 4 techniques gave the highest success rate of anesthesia compared to each other, combined with the initial inferior alveolar nerve block. And it will be of no surprise, based on the direction I'm trying to go here, that the infiltration with articaine had the highest success rate, 84%, compared to the intraosseous injection, which was 68%, the PDL injection, which was almost 50%, And the second inferior alveolar nerve block, which is what most of us would probably go to because that's what we were taught in dental school, that had the lowest success rate, only about 30%. What about in the maxilla? These were studies done in the mandible. This study looked at the same thing exactly, but in a maxillary molar and premolar. So here once again we have hot teeth, there's a pulpitis. The researchers did only a buccal infiltration, tested the success of pulpal anesthesia, articaine versus lidocaine. The success of articaine was 100% for both first premolars and first molars, and for lidocaine only 30% for the premolar and 80% for the first molar. Once again, as an infiltration drug in areas of infection and inflammation, articaine outperformed lidocaine. Brandt in 2011 did a literature search, so that's called a meta-analysis, where he compared articaine versus lidocaine. So what does the whole body of literature tell us if you add up all of the data and look at this as one study? Well, articaine is superior to lidocaine for infiltration anesthesia. In fact, it's 3.81 times more likely to give us pulpal anesthesia via infiltration compared to lidocaine. However, the literature does not give us good evidence that articaine is better as a blocking agent. The evidence is anecdotal, where a dentist will say, I've been using local anesthetics in my practice for years, and I have this patient who's very difficult to get numb, and articaine is better as a blocking agent for this patient. I can only get this person numb with articaine. That's a common example of an anecdotal report of articaine being better as a blocking agent. And a lot of people say this. A lot of people will swear that in their practices, they do better with articaine on certain people who are harder to get numb. That's a pretty hard thing to show in the literature. You can't really take these 1 out of 500 or 200 patients in our practice, pick them out of a research paper and see whether or not articaine works better on them or not. So maybe articaine, there's a reason to use articaine as a blocking agent for some people who are harder to get numb. Maybe anecdotally it might work better in certain situations. Another meta-analysis study, articaine compared to lidocaine, once again for symptomatic teeth, irreversible pulpitis. Another literature-wide search, this time done more recently in 2015. This time, the researchers didn't say that articaine was better in the maxilla. Their meta-analysis didn't find evidence for articaine being better as an infiltration drug in the maxilla. And once again, it didn't tell us that it was better as a blocking agent either. However, still, this second more recent meta-analysis told us that articaine was better as an infiltration drug in the mandible, and it was better as an infiltration drug after a failed inferior alveolar nerve block. Another interesting study that I found a year or so ago was done where they looked at, and this isn't about articaine, this is about local anesthetics in general, a theoretical thought. Is it possible that an injection of local anesthetic in a child younger than 4 or 5, that injection of local anesthetic could stop the development of a third molar? So we know that the third molar is the only tooth that develops after birth. And it also happens to develop in and around the area of where we give an inferior alveolar nerve block. So these researchers wanted to know if young children have an inferior alveolar nerve block, do they have a higher incidence of missing 1/3 molar? We know in the world about 20% of people don't get all third molars. So let's take a look at what they found. They studied children 7 to 12 years old who were missing 1 mandibular third molar. They compared children who had an inferior alveolar nerve block before the age of 6 to those who had not had an inferior alveolar nerve block. And interestingly, children who had an inferior alveolar nerve block between the ages of 2 to 6 had almost an 8% incidence of missing the third molar on that side. whereas if they didn't have an inferior alveolar nerve block, there was only a 2% incidence of missing one mandibular third molar. And this was, once again, statistically significant. Who knows why this is? It could be the pH of the anesthetic, the toxicity of the local anesthetic, maybe needle trauma, who knows? Interesting study, and maybe more will come of that down the road. The second last study that I'll show you has to do with local anesthetic safety in pregnancy. This was just in JADA a few months ago. We always wonder if local anesthetics are safe to give to our pregnant patients. And even still, even if it is totally safe, sometimes we second guess and maybe don't give local anesthetics to our pregnant patients in non-emergent care because we don't want a patient looking back at a past dental appointment and blaming that for something that's gone wrong in their pregnancy when there's no relation between the two. Anyways, this study looked at 210 pregnant women who received dental treatment. So they were pregnant. A little bit more than half of them were in their first trimester. And these women received root canal therapy, extractions, restorative treatment, and periodontal treatment, all with lidocaine. They compared pregnancy outcomes from these births to those from 794 women who apparently were not exposed to any teratogens during the course of their pregnancy. So they had no dental care, they didn't have any medical x-rays, they weren't taking any medications, they weren't smokers, there was no illicit drug use in these people that was reported. And they compared pregnancy outcomes in these women who apparently would have no reason to have any malformations or anomalies in their pregnancies compared to these women who had dental care with lidocaine. And there was absolutely no difference in pregnancy outcomes between these two groups. So this is as good a control as I think you could possibly find in a study like this. So the researchers theorized after the study that lidocaine and dental treatment during pregnancy do not pose a teratogenic risk. Well, I'd recommend that you read more about this, learn more about category A, B, C, and D drugs and which local anesthetics you might think about giving to your pregnant patients. Final study I'll show you is what is the least painful injection speed for giving an inferior alveolar nerve block. Malamed, in his excellent textbook, recommends injecting at a rate of 1 mil per minute. And so that's pretty much the rate that we were all taught in dental school and is the rate that many of us do in practice, although I think most of us probably push a little faster. This would mean giving a cartridge in North America in almost 2 minutes. One of our cartridges obviously are 1.8 cc's. Different cartridges in different parts of the world have different volumes, of course. So this study looked at the injection speed of 1 minute versus 100 seconds, so over a minute and a half, for an inferior alveolar nerve block with lidocaine. And between these two speeds, there was no difference in pain perception. So still a 1 minute injection speed, I think, is great for decreasing the pain associated with an inferior alveolar nerve block. But what's interesting about this slower rate of injection is that you actually get a higher success rate of anesthesia. This study looked at slow inferior alveolar nerve blocks versus fast inferior alveolar nerve blocks. The fast one's given over 15 seconds, the slow one's given over a minute, and you have statistically more teeth anesthetized with the slower block compared to the faster block. So not only are we being kind and gentle to our patients with slow injections, we're getting better anesthesia, at least for inferior alveolar nerve blocks. Part 2, new drugs. Let's take a look at two new drugs that have become available. One is called a local anesthetic reversal agent, and the second is more a class of drugs. There's 3 drugs I'll show you that are called periodontal anesthetics. So this local anesthetic reversal agent is called Oraverse. It's made by Septodont, and Oraverse is a drug called phentolamine. Phentolamine is a very potent vasodilator. In fact, in emergency rooms in hospitals, it's used as an emergency drug for people who have severe emergent hypertension. It lowers the blood pressure quickly by vasodilating. So the theory was if we vasodilate the tissue where the local anesthetic injection occurred, will we get a faster offset of anesthesia? And in fact, we do. Studies show that if you inject Oraverse after dental treatment with local anesthesia, I'll show you what the exact numbers, but you do get a faster offset of anesthesia, so faster local anesthetic clearance and less numbness after treatment. The volume that we would inject would be 1-to-1 with respect to our local anesthetic. So if we give 1 cartridge of local anesthetic, we would give 1 cartridge of Oraverse. Half a cartridge of local anesthetic, half a cartridge of Oraverse. And as you can see in this slide, an Oraverse cartridge is exactly the same as in North America anyways, a local anesthetic cartridge, and so it fits in our syringe quite nicely. So the indications that you might think of when using this product is to avoid self-inflicted injuries. Of course, we have this issue of people biting their lips after dental treatment. Special needs people, people who don't understand the feeling of being numb and it upsets them. If we can get faster offset of anesthesia, maybe they won't be quite as upset. It's indicated on children, of course, because children are very likely to bite their lips and they frequently complain about the feeling of being numb, but the child has to weigh greater than 33 pounds or 15 kilograms, 6 years and older. Diabetics, they can eat sooner if they're not numb for as long a period of time. People who talk for their work, they can go back to work sooner. Swallowing problems are alleviated. The ability to work bilaterally in the mandible, so we can work in both quadrants without the patient having that full lip-tongue anesthesia for a long period of time. And finally, for aesthetic assessment, if you're doing veneers or anterior aesthetic work and the droopy lip is making it difficult for you to assess the smile line, we can use Oraverse to reverse that soft tissue anesthesia, and then now we can maybe better assess our aesthetic parameters. Now, there are some disadvantages, as there would be for any drug or product. This obviously requires a second injection. So we have to sell this to our patient. Got to inject them a second time, and we all know that some of them don't even like the first injection, never mind the second injection. Also, there are certain procedures where you probably wouldn't want to use this. So sometimes we want our patients to be numb. If you're doing surgery or endodontic treatment, you want them to be numb for a couple of hours to let their body get on top of the inflammation that we've caused from the trauma of the operation. If they lose their anesthesia more quickly, they're probably going to have more post-op pain. It's also not indicated if we inject with a local anesthetic without a vasoconstrictor, there really isn't any significant improvement on the offset of anesthesia if you compare it to the duration of anesthesia with a plain solution. And finally, of course, there's a cost to this, and we have to consider that depending on where you are. It might be a few dollars per cartridge in order to use this product. So here's the studies that looked at soft tissue recovery time. They compared a phentolamine, an Oraverse injection, with a sham injection, soft tissue anesthesia in the mandibular lip, tongue, and maxillary lip. This is in teens and adults. And the offset of anesthesia was 70 minutes, 60 minutes, and 50 minutes versus 155, 125, 133, much longer with the sham injection compared to the phentolamine injection, again statistically significant. For children ages 6 to 11, comparing lip anesthesia, again 1 hour with the Oraverse, over 2 hours without. So again, significant, much faster offset of anesthesia. They did another meta-analysis survey to look at the time for soft tissue anesthesia, and it was significantly shorter in this meta-analysis look at the literature. And also they found that there were infrequent and minor adverse events reported, and the mild adverse events that were reported were mild heart rate increase in blood pressure, headache, injection pain, nausea, and these adverse events would be no different than the adverse events from an injection of local anesthesia. A class of local anesthetics is called periodontal anesthetics, and these are local anesthetics that are targeted to the periodontal sulcus. So they're not injectable. They're meant for scaling, to make our patients more comfortable when we're scaling deep pockets. There's one called Orachix. Orachix is by Dentsply, and this product is approved for use for scaling and root planing in adults. Now, this is a very interesting and brilliant product, and I'll show you why in just a second. But let me just give you some of the parameters of this product here before I do. It takes 30 seconds to work. The duration of anesthesia, soft tissue anesthesia, is about 20 minutes. So there's no root anesthesia or bony anesthesia. This is all soft tissue anesthesia. So no correction of root sensitivity at all. This is really just for the discomfort in the soft tissues. In places where hygienists are not allowed to inject local anesthetics, this is an advantage because the hygienist can apply the Orachix. And this is so-called needle-free. You'll see what the device looks like in just a second. So Orachix is a 5% local anesthetic. It is 2.5% lidocaine and 2.5% prilocaine mixed together. At room temperature, it's fluid. Now, the genius of this product is when it warms up to body temperature, that is when we squirt it into the periodontal sulcus, there's something inside the cartridge called a thermosetting agent. And it coagulates, it gels, and it doesn't run around and flow all over the mouth. It stays put in the periodontal pocket. The maximum dose for an adult is 5 cartridges. You would never need that much because you only require 1 cartridge per quadrant of scaling. So theoretically, you could do the whole mouth with 4 cartridges. Here's what the dispenser looks like. You have to depress the lever. Obviously, that's what squirts out the anesthetic. And the cartridge is the same as a standard North American local anesthetic cartridge, except it has this safety ring here that does not allow us to, by mistake, put it in our standard syringes. So we can't inject this by mistake. There was a multi-centered, double-controlled design, great studies done before this was released, peer-reviewed and all that, where they tested the safety and efficacy of this drug, and the pain scores were reduced by at least 50%, and there were no issues of adverse events, again, other than what you would expect from using a local anesthetic in this way. So safe drug to use on adults, and certainly scientifically is shown to reduce the pain that's associated with scaling these deep pockets. So here's a picture of me using this product in my practice. You can see that just above my cursor here, there's a little dab of Orachix, and when I remove the device, this little circle of anesthetic stays right here. This little bead, it doesn't go anywhere or flow away because of that thermosetting agent. So the idea here is to squirt a little bit on the gingival sulcus and then embed the probe into the sulcus and fill it up. Fill the sulcus up with the anesthetic, wait about 30 seconds, and the soft tissue should be anesthetized. The FDA approves this product for scaling. Any other indication, according to the product monograph, is off-label, but it can be used for other interesting uses. I'll show you a study in a second where it decreases the pain of retraction cord placement, or the removal of a temporary crown on an endodontically treated tooth, or rubber band clamp placement, or even the extraction of a very mobile primary tooth, where you can lift up the primary tooth, squirt a bit of Orachix underneath, let it sit down, and then maybe extract the tooth without having to do an injection. Or removing an implant healing cap with some soft tissue that's grown over. Again, these are all off-label, not recommended by the company, but this is a topical anesthetic, and there are other interesting ways that we might think about using it. So here's the retraction cord study where they compared the pain associated with retraction cord placement Orachix versus a placebo, and the Orachix group had significantly less pain when the cord was packed compared to the placebo. And if you're thinking of the palate in the maxilla, and this is exactly where I might think of using this, where this is a painful injection, an infiltration in the palate, certainly is one that's difficult to do without discomfort. Orachix might help in a situation like that. Contraindications are the same as any contraindication for lidocaine or prilocaine: an allergy, liver disease, methemoglobinemia. It's not indicated for people under the age of 18. Again, this is according to the product monograph. Precaution for people who are nursing or pregnant, and watching the toxicity with injectable local anesthetics. Of course, toxicity is all additive. So topicals, intrasulcus anesthetics, they all add up, and we have to consider that when we calculate our maximum dosages, especially for small individuals or those who might be a little bit more sensitive to the effects of the toxic nature of the drug. Two other products that I know that are available in the marketplace that are similar to this. One is called Hurry-Pack by Butlick. This is another intrasulcus anesthetic. It has a better taste for me than Orachix. It's cherry flavored, sweeter. Orachix is a little bit bitter. This is benzocaine, no thermosetting agent, but once again, it comes with the ability to introduce this anesthetic into the sulcus. So you see some bended tips here and a syringe. The syringe is used to suck the anesthetic out of the jar, and then once again, it's squirted into the sulcus. Another similar product, Cetacaine, also benzocaine with butambin and tetracaine. It's also meant for the sulcus. Also comes with a syringe and a needle which we have to bend. So very similar to the Butlick product, and will give us some soft tissue anesthesia of the sulcus, but once again, no thermosetting agent. So this one is more likely to spread across the whole mouth as opposed to stay put where we want it to be. So the final section in this talk will be new devices. These are all new gadgets that have become available or almost available in the marketplace, which you might consider looking at for your practice. So the first rule, this isn't really a gadget, this is more of a delivery system, and that is intranasal local anesthesia. So there's a push from one of our local anesthetic supply companies to supply us with an intranasal delivery system that will allow us to squirt the local anesthetic into a nostril with an atomizer that gives us the aerosol, and that will give us pulpal anesthesia. Now, the idea of putting local anesthetics into the nose is not unusual in medicine. Cocaine is put into the nose, tetracaine is put into the nose. It's something that's done in medicine for local anesthesia. It was found that there was some incidence of dental anesthesia, pulpal anesthesia, when intranasal anesthesia was done in medicine. And this kind of makes sense because you would imagine that if you squirt some local anesthetic into the nose, it wouldn't be hard for it to diffuse up to where the middle and anterior superioralveolar nerves exist, thereby giving us anesthesia of the teeth in the maxilla. So why not do this in dentistry and avoid doing an infiltration, especially in the anterior maxilla where infiltrations tend to be quite painful. There are some dental studies looking at the use of lidocaine in this way. So this is one such study that was done a few years ago where they compared intranasal tetracaine. Again, this is a medically recognized local anesthetic for intranasal anesthesia. So intranasal tetracaine with oxymetazoline. This is the vasoconstrictor that is added to the tetracaine. They compared this drug intranasally with an injection in the maxilla of lidocaine 1 in 100,000, and they tested pulpal anesthesia in the maxilla from the first molar to the central incisor. The successive anesthesia intranasally was 83% from the first molar to the central. It was better with the injection. However, if the researchers removed the first molar from the study, the success of anesthesia intranasally was 100%. Well, that's pretty telling and quite interesting. And it kind of makes sense because with the second molar, that tooth, the first molar, that tooth is innervated not only by the middle superior alveolar nerves, but also by the posterior superior alveolar nerves. So this is a good study to show us one day this might be a good way to give us anesthesia. A second new device that's come available in the dental marketplace, well, the first one's not available yet. This one is available, at least in the US. This is a buffering device called Onset. Now, Onset is by a company called On Pharma, and the theory here is to add a basic solution, that is sodium bicarbonate, to the local anesthetic cartridge. The thought is a more basic local anesthetic will be more advantageous. So it will work better in a number of different ways, and I'll show you what those ways are in just a second. In the US, this is FDA approved for use with lidocaine. And that's good because our lidocaine cartridges are the most acidic. We have a vasoconstrictor there. The vasoconstrictor has a preservative. That preservative is acidic. So lidocaine or any local anesthetic with the preservative, with a vasoconstrictor, will be an acidic solution. So what are the advantages of adding sodium bicarbonate? Here's what the device looks like when it's all put together. So here we have our local anesthetic cartridge. There is a sodium bicarbonate cartridge inside the device. It's a 3 ml cartridge of bicarbonate. And on the other end here is a volume control dial. And this volume control allows the operator to infuse a certain amount of local anesthetic, either 0.1 cc, 0.2 cc, whatever they choose, and that amount is replaced so it replaces a certain amount of local anesthetic. So if the operator dials in 0.1, then 0.1 mils of anesthetic comes out, and 0.1 mil of bicarbonate goes in. And then again, that bicarbonate makes the anesthetic more basic. So a more basic solution has the following advantages. Studies show that solutions that are more acidic hurt more when we inject them. There's good literature that proves that acidic local anesthetics are more painful when they're injected. Also, more acid probably causes more tissue damage, and that's part of what probably causes the pain. So having a more basic solution would mean less tissue damage, less pain, maybe even less post-op pain as well. Also, more basic anesthetics will actually work more quickly. They have a faster onset of anesthesia. Acidity gives us a slower onset of anesthesia. That's part of why our local anesthetics don't work when we're doing root canals and extracting mobile teeth in periodontal disease. Again, the acidity of the infection is stopping the local anesthetic. Will buffering the local anesthetic allow it to work better in these areas of infection and inflammation? And yes, it probably will. The pH of the anesthetic, if we can increase it from around 3.5, which is about what the pH of lidocaine 1 in 100,000 is, we add some sodium bicarbonate and we can make this more basic. I don't know if we'll get up to 7, but if we do, we can increase the lipophilic molecule in the local anesthetic cartridge solution by 6,000 times. Now this lipophilic molecule, this is the molecule that actually goes through the nerve membrane. When we inject a local anesthetic into solution, we have two molecules. We have one that's lipophilic and one that isn't. And having more lipophilic molecules in solution gives us better success of anesthesia and faster onset of anesthesia. So this is the theory of why using a more basic local anesthetic will give us more efficacy, especially in areas of acidity, infection, inflammation, and why using a more basic solution probably hurts less. So here's another meta-analysis, a literature review where Davis looked at not just dental studies, but studies in medicine, where buffered local anesthetics were compared to non-buffered local anesthetics for injection pain. It's over a 40-year span in the literature. And in all cases where buffered local anesthetics were compared to non-buffered local anesthetics, the pain elicited from the buffered anesthetic was less than the pain elicited from the non-buffered local anesthetic. The next category of newer products is needles. Now, why would we care so much about needles? There are some interesting factors that you might think about when you choose a needle next time you go to buy it. We always think about length, especially if we're doing inferior alveolar nerve blocks. We want to make sure our needle is long enough to get to the depth of where the inferior alveolar nerve happens to be. That's on average for an adult 25 millimeters. Gauge is important maybe because some of us think that thicker needles hurt more. However, I should point out that the literature does not support that thought. There are no good studies to show us that thicker gauge needles, fatter needles, cause more pain when we inject. However, one factor that we should consider with gauge is aspiration. If we're ever aspirating into places where there are the possibility of vessels, for example, an inferior alveolar nerve block or a posterior superior alveolar nerve block where we have the pterygoid plexus of veins, these are vascular areas. Larger gauge needles afford us the comfort of positive aspirations if we're in a vessel. 30 gauge needles, thinner needles, do not give us reliable aspiration even if we're in the middle of a vessel. Quality sharpness, of course, sharper needles are important mostly because they hurt less. The sharper the needle, the less tissue damage, the less pain our patients will feel, especially for deeper injections. And interestingly, needles actually have expiry dates, where after a certain shelf life, and usually it's about 3 years, there is not a guarantee of sterility anymore. So here's an example of some needles, some pictures, electron micrograph, where you can see some extra bits that I think would horrify us if these products were used in our mouths. These needles are going to cause tissue damage. They're not going to be ultra sharp. There'll be resistance. You use a needle like this for a block with this blunted end, it's going to be hard to push this needle 25 millimeters. It's going to feel like you're pushing through a very thick, dense block as opposed to tissue. Whereas ultra sharp needles here on the bottom right, these go in very smoothly, easily, less tissue damage, less resistance, and so on. So what's an example of one of these ultra sharp needles? Well, one needle that for inferior alveolar nerve blocks that I think is excellent, made by Septodont, called the Septoject XL. And the reason this needle is very good is because, number one, it's very sharp. Number two, it has a triple bevel. And with a triple bevel, this needle will not deflect. So single bevel needles, when we inject them 25 millimeters into tissue, they'll deflect away from the bevel, not giving us a straight line approach. These triple beveled needles or double beveled needles, they're straight on injections. They don't deflect very much at all. Now what's interesting about this Septoject XL needle is that you can see here on the top, this is the one that I'm talking about, the lumen is large compared to the needle on the bottom where the lumen is smaller. So these two needles in this picture, they're both 27 gauge needles. One has a large needle, one has a large lumen, one has a small lumen. The larger lumen on top happens to be the exact same lumen size as a standard 25 gauge needle. So this 27 gauge needle has a larger lumen, better aspiration, and straight on injection, very sharp. It's a good needle to use for your deeper injections. For your infiltrations, a newer needle that's come out in the last year or two is called Septoject Evolution. This is also by Septodont. This has a patented scalpel end. You can see the end of this needle has a completely different shape than the standard needle that we're used to. And this scalpel shape makes this needle ultra sharp. And when you use this in the tissue, we feel almost no resistance as we push this through. Now, this needle only comes as short and extra short, that is 25 millimeters, or 9 or 10 millimeters, the extra short, and so it's only for infiltration injections. This needle is so sharp that it's not indicated for inferior alveolar nerve blocks because of the risk of possibly damaging a neurovascular bundle or maybe the lingual nerve as this ultra-sharp scalpel type needle glances past it. This was the best needle in dental products in 2014. They did studies on silicone blocks. It took less force to inject, and even after the fourth injection, the septeject evolution was sharper and required less force than the standard needle in its first injection. So it stays sharp after multiple uses. The next new product is a vibration device. This is called Dental Vibe, and it comes in an adult version and a pediatric version. And this is kind of like a lip shaker. Some of us, when we give injections to dissociate the patient's mind from what we're doing, we shake the lip. Well, this is an automatic lip shaker. It doesn't just shake the lip. It shakes wherever we put it, thereby dissociating the patient from what is actually happening to them. Now, they were smart enough to maybe supply these little finger puppets for kids, so the kids are looking at the finger puppets while they're being injected. That's a neat diversion tactic. And also, they have 3 attachments to the device. There is an infiltration attachment for moving the lip away from the buccal sulcus. There is a palatal attachment, and there's a block attachment where you would put the prong sort of around the area of where the needle would enter for an inferior nerve block. Basically, the vibration is applied to the tissue in the area of the injection. It's a great idea. Used by some people. It has some other devices. It has a flashlight. It has audible sound, which is also a distraction. A recent study done at Tufts to show that on adolescents, that people who had this device used on them had significantly less pain compared to those who only had an injection and no vibration. You all heard of the wand. This has been around for a while. I'm presenting it not because it's new, but because it's been rebranded. It's now carried by a different company, Aseptico. And instead of being called STA system, which stands for single tooth anesthesia, it's now called the wand once again. So at first it was called the wand, then it was called STA. Now once again it's called the wand. This device does quite a lot of really neat things for us. First of all, it has a pressure sensing technology. So there's a feedback to the computer being the main unit here. And when the needle enters the tissue, the feedback goes to the computer, telling the computer how dense the tissue happens to be, and it can change the speed of the injection based on the density of the tissue. So if you're doing a PDL injection, this is great. Where the needle gets into the PDL space, it automatically will give us a nice slow speed of injection. And there are 2 speeds that this computer can provide to us. A slow speed, where the injection happens in about 4 minutes for a full 2 mil cartridge, or a fast speed, where the injection happens in about a minute. So the slow speed is ultra slow. It's a drip at a time. And there are lots of studies to show that slower speeds hurt less. And with the wand, this is especially apparent. They've done studies where they've looked at infiltration anesthesia in the palate, and we can give quite painless injections in the palate with this device. Here's the slow drip, drip, drip with the 4-minute full cartridge injection. Although you would never keep this on for 4 minutes, it wouldn't be necessary. You get the few drips, give you soft tissue anesthesia, and then change the speed to the second faster speed and give the rest of the volume that way. And holding this like a pen instead of this more awkward needle and syringe way gives us a little bit more versatility in where our hand position might be. Another computer-controlled device which is new is called CalEject. And this is very similar to the wand with a few differences. One difference is, quickly I'll go back, with the wand, this whole system is disposable. So there is a disposable cost and a repurchasing that has to occur. With the CalEject, this part of this system, none of it is disposable, of course, except the needle. The rest of it is sterilizable, so there's a savings in disposable cost. So that's one difference with this device. The other difference is this has 3 speeds, and the speeds are based on the type of injection you're doing. So there's one speed for palatal PDL, there's one speed for infiltration, and there's one speed for block. So you basically set this machine up based on what type of injection you happen to be doing in the mouth. This is another good way to give our patients comfortable, slow injections, maybe a bit of a gadget like the wand, but these gadgets can be good practice builders, and for kids, children seeing this type of a device and this type of a device might not get quite as scared as looking at this type of a device. So some practitioners like to use these on children to allow them to accept receiving an injection more readily. The second last section that I'll talk about is needle-free injectors. So these are injectors that can push the anesthetic into the tissue under a great amount of pressure without a needle. 2 older ones that have been around for a while, Sirajet and Metajet, really don't have good dental application. But another one which is newer to the marketplace is called Injex. Now Injex, apparently, it's released in Canada, and there's a group in the US who are working now to release it to the US marketplace. So this is Injex here when it's all set up. This is an ampule of anesthetic. I'll go back quickly. You have to transfer the local anesthetic from the cartridge to the ampule down here. You put the cartridge in this transporter, put the ampule on the end here, turn the transporter, and that squirts the anesthetic into the ampule. Then you attach the ampule to the injector. The injector is set by putting it in this reset box, closing the lid. That sets the spring inside the injector. You get about 0.3 mils of anesthetic, so the maximum volume is quite low. So it's hard to get good anesthesia in certain areas of the mouth. In fact, really this only works in the anterior area. Maybe premolars, but more for anterior teeth. The green ring is moved this way. The lever can now be depressed. The spring lets go. You have to keep this against the tissue or else it causes some tissue damage. There is an incidence of hematoma and bleeding sometimes when this is used. But for our patients who are needle phobic, this might be advantageous for certain procedures in the anterior part of the mouth, no needle, and there is some degree of pulpal anesthesia. I've had this done on myself. It feels different than an injection prick. I won't say it hurts any less or any more. It just feels different. It's kind of like when the spring lets go, it's kind of like the feel of an elastic band, a little elastic band being slung against the tissue. So what does the future hold? I'll end and then we'll take some questions. What does the future hold? I think one interesting thing that might be coming down the pipes is a topical anesthetic that might give us pulpal anesthesia. Wouldn't it be great to have topical anesthetics where we just spread the topical on gingiva, wait a little while, and get pulpal anesthesia? So that would be neat to have in the future. Another interesting thing that we might have one day is pain fiber specific local anesthetic. That is a local anesthetic, it's injected, it only anesthetizes pain fibers. No sensory fibers, no motor fibers, so there's no paralysis from the injection of the local anesthetic, only blockage of the pain message. And finally, I think intranasal anesthesia is one thing that's closer for us to receive. This is, I think, something that may change our ability to give maxillary injections, and also not to mention, as I started with, is the ability to use articaine in the mandible as an infiltration drug. So that's my talk for this evening. Thank you for attending.